All right, welcome everybody. I see we have people joining. So we're actually going to just do some housekeeping stuff while people are getting situated before we get into the topic this evening. So first of all, this webinar is done, or sorry, this VMU is done in webinar format. So attendees on the call, you are muted sorry about that. You are muted and your videos are turned off. We do encourage questions throughout the presentation, whether you want to ask them while Dr. Felton is talking, or if you want to wait until the very end, we'll have time for Q&A. Either is completely fine. John and myself will be monitoring the Q&A section. Go ahead and submit your questions in the Q&A or the chat. That's fine. We'll check both of those. We are recording this VMU tonight, and it will be up on our website, which is epilepsywisconsin.org within the next week or two. John, I'm gonna have you put that stuff in the chat like you usually do, please. Thank you. And you can find it underneath, if you go to our website, you can find it underneath our video library tab. I believe that's going to be all the housekeeping stuff for this evening. So I just want to make sure participation is okay. Yep. So without further ado, welcome everybody. We're really excited for this week's virtual meetup. We are doing a series on women and epilepsy. Very, very excited every Thursday this month. My name is Alicia Thompson. I'm the program manager here at the foundation. We also have John with us.
Good evening, everybody. John, work with Alicia at the foundation, primarily with communications and client support services.
Thanks, John. So like I said, we're focusing on women and epilepsy this month in October. And the first topic tonight is all about treatments. So we're very excited. If you've joined us before, you have seen Dr. Felton before, but we're really excited to have her with us. So Dr. Elizabeth Felton is an assistant professor of neurology at the University of Wisconsin-Madison. She's board certified in neurology and epilepsy. Her epilepsy specific clinical interests include the ketogenic therapy for adults, special issues affecting women, neurostimulation, and pediatric to adult transitions. She's also is the UW Health Ketogenic Diet Program Director and Women's Epilepsy Clinic Co-Director. And then she also is on our professional advisory board here at the foundation. So Dr. Felton, thank you so much for being with us. I'm going to pass it on over to you.
Awesome. Thank you so much for having me. I'm really excited about doing this tonight and participating for the rest of the month as well. I'm going to share my screen here. There we go. So what I thought I would do this evening is spend about 20 minutes or so talking kind of in broad level about the 4 main treatments for epilepsy. A little bit about each of them. This is part of a 4-part series that we're doing this month. I'm doing the first 2, and then Dr. Ann Josiah is doing the last 2. And we hope over the course of the month to cover treatments, hormones, contraception, and pregnancy. So some of the topics that I talk about tonight, I may not get too in-depth about if it's related to one of the other topics, because we're going to take a deeper dive on a future week. So hope that you will join us for the whole month. And Dr. Josiah and I are the 2 co-directors of the Women's Epilepsy Clinic at UW Health. I'm just going to highlight this website, myepilepsystory.org. It's a specific organization focused on women with epilepsy. And so just a good resource for people to check out. Okay, so when I think about epilepsy management options, I break it down into 4 main categories. So drugs, surgery, devices, and diet. As you heard earlier, I am the Ketogenic Diet Program Director at UW Health. So that's a really big thing for me. And you'll probably see that my section on the diet might be a little bit longer than the others, but I work with all these treatments, and we'll talk about some specific considerations for each of them. So first on medications. So when we think about drugs for epilepsy, the current term for these is anti-seizure medications. You may have also heard anti-epileptic drugs. It all kind of means the same thing. It's the most common treatment of the 4 categories of treatment. And it's a typical starting point. Almost anybody with a new diagnosis of epilepsy, the first treatment that they're going to try is medication. There's more than 20 available, and then there's always more coming out in the pipeline. So you'll always hear, oh, new drug for epilepsy, or that's either in a clinical trial or FDA approved. Don't worry too much about the details on this chart. It just kind of shows on the x-axis here, the year of introduction, and then the number of anti-seizure medications. So, back in the 1800s, we had bromides. In the early 1900s, we had phenobarbital. And then we started development of some of our medications, which we now kind of call like a little bit of like older medications, like phenytoin, for example, primidone, ethosuximide. And then more recently, since 1990, we've had, what is this, maybe 15 more medications that have joined our ranks. And so, we still do sometimes use the older ones. We still have people on phenobarbital, which has been around since the early 1900s. But now we're also using some newer treatments as well. And some of the differences between the older and the newer treatments are often the side effect profile. So the older medications do tend to be quite effective, but may have undesirable side effects in a variety of ways, including specific for women with epilepsy. Some of them are what we call teratogenic, meaning that if you were to get pregnant, it could negatively affect the fetus or unborn child before you, if you take that medication while you're pregnant. So just some high-level considerations. So potential for side effects. So polycystic ovarian syndrome with certain seizure medications. So for example, valproic acid, also called Depakote, can have that as a side effect. Interactions with other medications. So for people that are taking hormonal contraception or gender-affirming hormone therapy or hormones for other reasons, there can be some interactions with the seizure medications, and those can be, depending on the medication, it can be a two-way interaction, meaning that the seizure medication can impact how effective the hormonal medication is. So for example, if we're talking like about a birth control pill, the seizure medication may lower the effectiveness of the birth control pill, making it more likely to get pregnant. If that's what's trying to be prevented by the birth control, that would be something that you would want to know about. However, it can also have an interaction in the other way, where sometimes the hormonal medication, or say a birth control pill, may change the level of the seizure medication. And so you may need to adjust the dose of that. So it's just something to be aware of. And what I recommend is just whenever you're prescribed a new medication, if you're on a anti-seizure medication, is to ask the prescriber, is this going to impact, is there an interaction between these medications, just to make sure. And then pregnancy-related considerations. So the potential for teratogenicity, I touched on that a minute ago. So when you're pregnant, there are certain anti-seizure medications that are considered safer than others. And so that's something that you want to be aware of if pregnancy is even a remote consideration. And then as well, that dose adjustments are often needed during pregnancy of the seizure medication. So even if you were on one of the anti-seizure medications that we consider one of the safer ones, we may need to adjust the dose during pregnancy because the metabolism of the drug changes when you're pregnant. And then just a side comment is that breastfeeding is generally encouraged with women with epilepsy. So, and I'm mentioning this because I've had a lot of patients come to me and they were told, oh, I was told I could never get pregnant, or I was told that I could never breastfeed. And that's not true. We can work together typically so that that can be a possibility. And then another consideration is bone health. Of course, this is important for everyone, men and women, but sometimes women can have a higher incidence of osteoporosis and things like that as they get older. And so really a good focus on maintaining healthy bones, even when you're young. And so that's typically what I do is I check vitamin D levels periodically. And if the vitamin D level is low, we supplement that. Some of the anti-seizure medications can actually impact bone metabolism, impacting it. Also thinking about, seizures. If you're having a lot of seizures where you're, falling down, you could have injuries, fractures. And so we really want to maintain good bone health. This is another great website, the North American Anti-Epileptic Drug Pregnancy Registry. The website's at the bottom. There's some good information on that website for women who are pregnant or thinking about becoming pregnant. And I encourage all of my patients to join this registry if they are pregnant. A lot of the information that we have about the impact of the seizure medications during pregnancy actually comes directly from this registry. And there's actually, this is the North American one. There's several other international pregnancy registries. And so we look at the data from all of those. So questions to ask, if you're prescribed a new medication of any type, just say, are there any interactions with my anti-seizure medications? The prescribing provider should be able to do that. And if they can't, you can ask the pharmacist. If you come to UW Health, we have a epilepsy clinic pharmacist who you can contact, and you can always check. And then when adding or changing hormonal contraception in particular, finding out if that interacts with your seizure medication and if there needs to be an adjustment. So for example, I've had patients who were taking a hormonal contraception and then they stopped it. And, why would they think that they need to contact me? That probably, you'd think that has nothing to do with your seizures. However, that interaction, if you take away the birth control pill, that may change the level of the seizure medication in your system. And so sometimes we need to make an adjustment to account for that. And then if considering pregnancy, checking in with your epilepsy provider, asking, do we need to check medication levels and do we need to make any adjustments? So being very proactive about these questions is good, good practice. Okay, so now I'm going to move, and this section is actually going to be pretty short, is surgery. So typically we're considering surgery if a patient has a focal epilepsy and a lesion, and we think that we can perhaps remove that lesion and, basically try to make their seizures go away. It is considered the best chance at seizure freedom. We often have to do a workup, including an admission to our epilepsy monitoring unit and a bunch of tests. And the main options are an open resection or laser ablation. And I won't get too in the weeds with those. But the high point is that for women with epilepsy, there's really no major interactions or complications specific to women. Rarely, depending on the surgery or the lesion, you may need to avoid a vaginal delivery when having a baby, just due to the pushing and the increased intracranial pressure that can cause. But just having epilepsy surgery does not automatically mean that you have to have a C-section when you have a baby, but there are some rare considerations for that. And so that would be just something that you would want to ask about if you're in that situation. Okay, now I'm going to move to ketogenic diet therapy, which, as I mentioned earlier, is kind of my area of expertise. These pictures here were all taken by the dietitian that I work with, Kelly Faltersack. She's tested a lot of recipes that we use, and these are all keto approved foods. So ketogenic diet therapy is basically a medical nutrition therapy, high fat, low carb, moderate protein diet. It's designed to kind of mimic the fasting state, and it forces your body to use ketones or fat and thus ketones for energy. The liver makes ketones, and the brain and other tissues can use that as its primary energy source. And it has been shown to reduce seizures in people with epilepsy. In terms of pregnancy and ketogenic diets, there's just insufficient evidence on its safety. No doubt there have been people who have been pregnant on a ketogenic diet, but really in terms of, the evidence-based information in the literature, there's just not very much out there. So there's a case report, which I did a screenshot here of 2 patients that had successful pregnancies while on a ketogenic diet. One of the infants had a minor ear malformation that may have had nothing to do with them being on a ketogenic diet. But the data from the ketogenic diet is not included in any of the pregnancy registries. I had mentioned there are several international, those mostly focus on medications. And so we really just don't have enough information to say whether or not it's safe. So the approach at my clinic is that if a patient says that they're planning to consider pregnancy within the next year, I usually just don't recommend that we don't start it at that time, that they wait until they're done having children, and then we would do it. If pregnancy is more of a distant option, a year or more, then I think it's reasonable to give a try. Like, let's see if it works. Maybe it's not even going to work or not going to be compatible. And if it is, then we have some steps we take, which I'll talk about on the next slide. But in my practice, get a baseline pregnancy test before starting a ketogenic diet, recommend contraception. And then this fourth bullet about the prenatal vitamin plus minus folic acid, that's like a universal recommendation for me. Of all women of childbearing potential in my clinic, I recommend that. And then I have my patients, again, all women that I see, I recommend that they track their menstrual cycle along with seizures and ketones. And I generally have a low threshold for pregnancy tests if a patient contacts me about missed menstrual cycles. So some of these things, these last three bullets, are really like kind of universal recommendations in my clinic, not just for ketogenic diet. Excuse me. And then in terms of pregnancy planning, so if I have a patient who's already on the ketogenic diet and they say they want to become pregnant, we see let's see how effective has ketogenic diet been for that patient. If they have accidentally or intentionally bumped out of ketosis, does that automatically trigger a seizure or not? And then we discuss the potential benefits and risks. And generally, I recommend that we wean to a version of ketogenic therapy where they actually aren't in ketosis anymore. It's still low carb, but not in ketosis, because it's the state of ketosis that I just don't think we have enough data on how much that impacts the pregnancy. And then if they are on a ketogenic diet and they become pregnant, like an unintended pregnancy, for example, we, again, weigh the individual risks and benefits at that moment, and we may consider a wean as above. The reason that I'm a little more cautious about that, even if a person is on an anti-seizure medication, that is one that is considered riskier to a pregnancy, we don't always change it during pregnancy because the risk of destabilizing seizure control is risky. And we want to be careful about that. So in a pregnant woman, we don't want all of a sudden to take away a medication or a treatment such as ketogenic diet that had been very effective and then make them have increased seizures during pregnancy. And then I work with their obstetrician gynecologist. Okay, so we're on our last of our fourth and last treatment of our whirlwind tour here. So neurostimulation. So basically neurostimulation is excitatory stimulation that can help prevent and shorten seizures. The exact mechanism of how it works is poorly understood. And it's a good option for patients with intractable epilepsy who can't get surgery. Other advantages are that there's really minimal side effects. It doesn't interact with medications. There's no teratogenicity, so it doesn't affect a pregnancy, at least not that we know of. And you can ignore the last bullet. I'm just going to briefly talk about each type of neurostimulation. So like the vagus nerve stimulator has been around the longest. It was FDA approved in '97 for focal epilepsy, though it is also used off-label fairly commonly for generalized epilepsy. It's also approved for depression, and it delivers stimulation to the vagus nerve in the neck. There's a battery pack in the upper left chest. And the main consideration for this, the location in the upper left chest area, is that it potentially could be over breast tissue, and that could make identifying a lump, for example, on a manual breast exam difficult if it were to be like directly under the device. Similarly, special positioning is required if a woman is having a mammogram. And there can be some MRI limitations. I mean, you can get an MRI with a VNS, but there's some limitations for chest MRI. And then if radiation is needed, the device may be damaged. And so it's just something I wouldn't like not have a woman get a VNS, but it's just something to be aware of. And when a woman goes for a mammogram, just make sure they know that she has a VNS so that they can get some good images under the device. Responsive neurostimulation, or RNS, was FDA approved in 2013 for people with drug-resistant focal epilepsy. The battery pack for that is put in the skull, and the electrodes are put into the brain, and it continuously monitors brain activity and delivers stimulation to abort seizures. And there's really no known contraindication or concerns for women with epilepsy for this device. And similar for the DBS, or deep brain stimulator, this one was FDA approved in 2018, also for focal seizures. It goes into the anterior nucleus of the thalamus. This one has a generator in the chest, which I suppose would have the same issue as the VNS in terms of the placement of it. And actually, I have not read about that, but it has been around less often, at least for epilepsy. But just something else to consider about the location of the generator in the chest. And in terms of pregnancy, basically this slide is saying that there's little data, but no indication that there's any issue with it for women with epilepsy. So that's the end of our whirlwind tour. 4 main treatments for epilepsy: medication, surgery, ketogenic diet, and neurostimulation. The high points are that for medications, you need to think about interactions with things like hormonal contraception and also safety during pregnancy. For surgery, there's really no main concerns. The main thing is whether a woman can have a vaginal delivery. For ketogenic diet, generally not recommended during pregnancy, but sometimes we can do a low carb version where you're not in ketosis. And then neurostimulation, generally no issue, but just needing to think about monitoring for breast cancer under the device when it's placed in the chest area. The 2 web links I have here are for the North American Anti-Epileptic Drug Pregnancy Registry and the My Epilepsy Story, which I just thought were 2 good resources for women. And then just one more plug for the rest of our series. Every Thursday, I'm doing next week on hormones, and then Dr. Ann Josiah on contraception and pregnancy. And I do want to take questions. I mean, I wanted to kind of do a quick overview and then really just open it up for any questions or discussion or comments that you have.
Great. Thank you so much, Dr. Felton. Yes, it looks like we do have some questions here.
Okay, great.
I can take the first one there. Look, out of all 4 treatments, are there any that universally work better with women rather than men?
Universally work better with women than men. I wouldn't say that there's any that specifically work better with women. I mean, I think most of them are equivalent, and just some of them maybe have some cautions for women, but I wouldn't necessarily say better.
Okay.
Let me just say one more thing. So that question was about the 4 treatments. There certainly are medications that are probably better for women.
The next question.
Better choices for women. Okay.
Medicines that tend to work better with women rather than men. That was the next one coming up.
Yeah, thank you. So I wouldn't necessarily say better in that it's more effective in women, but better in that, there's certain side effects and things that we might want to avoid in women. So for example, I had mentioned polycystic ovarian syndrome with Depakote or valproic acid. We want to avoid that. Valproic acid can also cause unwanted hair growth, like on the face in women, and can cause like hair loss, which can be, an undesirable side effect. And so in women, I generally, if a patient hasn't tried any medication, say they're a new diagnosis of epilepsy and we're going to start a first medication, usually Lamotrigine, which is Lamictal, or levetiracetam, which is Keppra, are my top choices, because those are generally the 2 that we have the most data on for pregnancy and are the safest, and also have in general a good side effect profile. Between those 2, there are pros and cons of each of them. One con about Lamotrigine is that one does specifically have interactions with hormonal contraception, whereas levetiracetam or Keppra does not.
Okay.
So it's all kind of a balancing act, and it's kind of, I customize my recommendations for each patient.
I have to ask a follow-up question on that one too. One of the
Please.
pieces of information that tends to go out there, and just whether or not it's a myth or whether it's truth, is women should avoid Depakote. Is that true, or?
Yeah, I mean, so it's not that they can't have it. It's just because of those side effects. So if a woman is like potentially remotely might become pregnant, I would really try to avoid that medication, just because it can be very risky to the, if they were to, to the fetus, if they were to become pregnant. Meaning, what I mean by that is high risk of birth defects. And so that's one of the main reasons Depakote is avoided. That being said, Depakote is a very effective medication. It really works well. And I have some patients for whom that is the most effective medication for their seizures. And so, I have some women on Depakote, and, we just, if they're not of childbearing potential, or if they're not planning to become pregnant, then that's okay. If they are, then I have them on high dose folic acid and strongly recommend effective contraception.
Okay. Well, so long this, I think you touched on this already, but I'll just ask it anyway. Are there any
Sure.
medicines to avoid if overall she intends to be or is pregnant?
Yeah, so Depakote is the main one, but there are other ones, and it's all kind of in a spectrum. And so like Depakote would be like, I really want to avoid that as much as possible. Keppra or levetiracetam and Lamotrigine, are kind of like my favorite ones. And then other things are kind of in the middle. And so, like phenytoin and phenobarbital, I would ideally like to avoid also. Clobazam, though I've had patients on clobazam during pregnancy, but it's maybe not the ideal one. Cannabidiol, which is Epidiolex, we just don't have enough data on. Some of them we just don't have enough data on yet. We just don't, like the registries only publish data on the medication once they have enough women who've been on it. And so for some of them, particularly the newer medications, we just don't have that information yet.
Okay. Let's see here. What are the medicines? Excuse me, why are the medicines always the first place to start with a new diagnosis? That's more universal, but
Yeah,
came up.
that's a very good question, actually. So yeah, I mean, medication, I think of the 4 options, so I'm going to kind of talk about it like in reverse. So neurostimulation and surgery, both of those require surgery. So when I say surgery, I'm kind of talking about like resection or laser ablation, and then neurostimulation are the devices, but those all kind of require a surgery. And for most people, we're not just going to immediately jump to a surgery if a person has had a couple seizures, because it just may not be necessary, or depending on the epilepsy type, it may not even be an appropriate treatment. Ketogenic diet as first line is typically not done, though I do have a small number of patients who have tried it as a first medication, or as an only, not medication, treatment, or as their only treatment. But it's very difficult to maintain a ketogenic diet 100% of the time. And if you come out of ketosis, you're at risk of having seizures. And so medications are really just the most straightforward. It's kind of like it's just the easiest, but not everyone feels that way. I recognize I have patients who hate taking pills, and they want alternatives. And so then we work to find those. But for most people, that's just kind of the starting place, because it's the most straightforward thing to do. And for 1/3 of all newcomers with a new epilepsy diagnosis, 1/3 of them will get very well controlled, basically seizure free, on the first or second medication that they try. Another third will get to that point, but probably is going to take some more tweaking and more medications. And then 1/3 are in the intractable category, where they're continuing to have seizures despite whatever you do with the medication. And so it's that last third that we really are looking at these other treatments for, meaning the surgery, neurostimulation, and diet. And so 2/3 can, just with medication can have their seizures well managed. So that's why it's tried first. That was a long answer, but I wanted to kind of parse it out a little bit.
Thorough and helpful.
That's great. Yeah. We do have one asking for clarification. So can a woman breastfeed and be on the keto diet? Because I know there needs to be more calories when somebody's, breastfeeding. So if you could talk about that.
Yeah, so it's not so much a calorie issue. You can get enough calories while breastfeeding. In terms of a woman being, so in terms of that, so we usually wean a woman to a version where they're not in ketosis during pregnancy. And we recommend that they stay in that during lactation, during breastfeeding. A low level of ketosis is probably okay, but we don't advise that a woman is in like a large, there's like gradations of ketones. We don't want them to be in a high level of ketosis during breastfeeding, ideally, because we just don't know what the effect of that, particularly if the baby is only getting breast milk. If they're also getting formula, which, is not going to be ketogenic, then maybe it would be okay.
That makes sense. Yeah. Thank you for clarifying. John, do you see any other questions?
Yeah, one other one. Are there any medicines in particular that will adversely affect a woman's menstrual cycle?
Yeah, that's a good question too. So, I mean, again, Depakote is just terrible. Depakote can impact with the whole polycystic ovarian syndrome and irregular menses and things like that. Most of the other medications don't directly impact the menstrual cycle. Ketogenic diet, we have seen some women have some menstrual cycle changes, irregularities and things like that while on a ketogenic diet. And that could be for a few reasons. Whenever there's like a big change in diet, that can impact the menstrual cycle. Similarly, losing a lot of weight can as well. But other than that, it's, I'm just thinking if I'm missing any off the top of my head. There aren't others that we typically think about as affecting the menstrual cycle. That's not to say that there might not be others where like it would be like a rare side effect.
Alicia, that's all I'm seeing for right now. Any of you in our listening audience tonight, now would be the time to submit a question if you do have any others.
Yes. So Dr. Felton, I was just going to comment, I guess. It sounds like it's very, because I'm still learning this stuff as well, of course. But it sounds very individualized, just like, any woman getting pregnant. Doesn't matter if she has epilepsy or not, right? It sounds very individualized, and like you need to go talk with your provider and kind of come up with a plan. And so I think that this was really helpful to kind of just bring that to light. And so thank you. It was great.
Yeah, I mean, I think, maybe like the main takeaways are that, one of the slides that I had in there was about questions to ask and really asking about interactions and things like that. Because I've had many patients come to me, who started a medication, was prescribed by somebody else, and they just didn't realize that there was that interaction and no one had told them. And then it's like impacting their seizures. They're saying, oh, my seizures are increased. And we say, okay, like, well, what's going on? There's a new med. And then we find out that there's some interaction. And so that's not isolated to women, but I guess maybe it comes up more with women because it's often with these birth control pills, the hormonal contraception, which is not contraindicated, but it's just that we have to think about these interactions. And then the issues around pregnancy and women being told that they can't get pregnant or can't breastfeed, which in most cases is just not true.
Right. Okay. All right. I don't see any other questions. So I think that will wrap up our VMU for this evening. Dr. Felton, again, thank you so much. We really appreciate your time. And thank you to everybody for joining. I'm just going to say it one more time. I know Dr. Felton had it up on the screen already, but we do have next week, so October 14th at 7. We are talking about hormones next week. So you'll get to see Dr. Felton again. But again, thank you, everybody. Have a great night, and we'll see you next week.
Good night.
Thank you.
Good night. Thank you.